other people who are unable to be with us this evening will be able to benefit from some of the insights and ideas that are being shared. So that's an important piece of what's going on. I'm also going to open up some of the links so that we have them. And I will be showing you how to do that. So there's a button called Share Screen. And so I will be on occasion sharing, or if our speakers want to share something, they'll be sharing it. So you should now see something on your screen. Do you guys now see? And give me a thumbs up or something like that if you can see the email that I sent out last night.
I can see it.
Excellent.
Yep,
And,
we see it.
yeah. And then below are some of the resources, including the video and some of the documents, those FAQs. I will put some of those links in the chat box so that you can get them as well. So I will now take us off screen sharing, but now you know how to use that, and that will be another tool that we can put in our portfolio in our new Zoom existence that can help us. Right now, it's my pleasure to welcome two wonderful medical professionals. And before I welcome them, I want to just share a traditional bracha to help frame this conversation and bring it into a Torah context. One of the things that we do regularly as a community is we pray for the well-being of all those who are ill. This is my first time living through a pandemic, and maybe yours as well. And so I've been holding a lot of people, the regular list of people that I've been holding, people who are dealing with other medical situations, and now people who are dealing with this virus. I have a cousin of mine who is coping with this in an ICU in Westchester. And so this is very, very real and present for many of us. Many of us know family members, friends, or even maybe one step removed from someone who has this virus, who maybe is battling with it at home. Maybe they have a more mild case. Maybe they have symptoms. Maybe they've been tested. Maybe they haven't. But this is very present for us. And we're always reciting that Misha Berach prayer. And in that prayer, we not only hold up all those who are ill, and then we pause and add other people in our lives, but we also think about those who are the caregivers. Those are the people who are delivering the care and support. And if ever there was a time that we need, and we have the most amazing doctors, public health officials, researchers, scientists, and especially those on the front lines like our nurses and others who are treating people and placing their lives at risk to help the world, this is such a moment like that. Isaiah says in this week's Haftarah, right, he says, Atem Edai, you are my witnesses. And what does it mean to be God's witnesses? It means that we are instructed to live such a life of Kedusha, of holiness, such a life of moral and ethical living, that we become God's witnesses in this world. And Atem Edai means that we are supposed to be God's hands. The rabbis take it even further and they say, right, that what does it mean, Atem Edai, you are my witnesses? That if you live that kind of life of holiness, of ethical elevation, then you are my witnesses. But if you are not living that life, then I have no witnesses. It's as if God is not God, right? God only becomes fully actualized when we become God's hands. And if ever there was a time for amazing medical professionals, people involved in public health, people who are treating people, working in hospitals, this is such a moment. And so I hold them all with a prayer for their well-being, for their insights, for their wisdom. That is truly one that can sustain us through this time, and offer them bracha from the bottom of my heart, that they are given God's hatzlacha, that they are going to be blessed with success during this time of challenge. And I hope we can all, in this virtual moment, say, Amen.
Amen.
We're going to turn it over to Wendy and to David. Wendy is a faculty member at the Department of Environmental Health at BU's School of Public Health. And David Geller is the founder of Bedford Pediatrics. Both of them are involved in the discussions about the coronavirus on many levels and have been instrumental in advising me and many other leaders in the shul throughout the last few weeks as we've been making numerous changes on this journey. And they both serve as on the Lexington Board of Health, making decisions for our schools and our local community. So I'm going to turn it over, I think, first to Wendy and then to David. And then we'll invite everyone to type questions into the chat room. And that's how we'll be going back and forth. If everyone else can remain on mute so we can hear from them, that would be great. And if there are things, documents to share, I will put those in the chat room or on the screen.
Sure.
Bevakasha.
Thank you. Thank you, Rabbi, and my friend David Geller, with whom I think we have 75 conversations a day. So I'm going to start with my professor hat, because as a professor of public health, this is what we think about. We think about the public, right? We think about communicable diseases and how we can control them. And at the in Massachusetts, we have a very interesting situation from a regulatory perspective, which is slightly different than the other 49 states. So when we say the CDC is in control of what we do, we actually don't really mean that. What we mean is that in Massachusetts, we have a State Department of Public Health, and the State Department of Public Health defers on decisions around communicable diseases to the local boards of health. There are 351 local boards of health. We're called the locals. And the responsibility of the locals is actually amazingly overwhelming. And as you can imagine, as we get further and further from all the wonderful healthcare that the rabbi spoke about and the systems in Boston heading out further west to the Berkshires, there is less and less capacity of the local boards of health to make decisions to protect the communities and make decisions around control of communicable diseases. So we got our mandate, locals did, at the time of Paul Revere. That was a long time ago, and we really haven't changed much, except that the costs of doing business and the numbers of people have significantly increased. So what this means is that your local board of health is responsible for controlling communicable diseases. And so in the towns in which I would venture to say all of you live in, you have a local board of health, but you also have a health department. And that health department includes a health director, health agents, et cetera, and so forth. And the local board of health has an advisory, a policy role that grants authority to the health department to make the decisions. So we have been working around the clock, as have many of you who, my next door neighbor, Grant Street is like this crazy place. We start on Zoom at 6 o'clock in the morning. So anyway, we have been addressing a number of issues around the science of COVID-19, which is the disease. It's a disease caused by a virus called SARS-CoV-2. I'll spare you my lecture. I'll simply post it so that you can see where this virus comes from, how it's gotten to people, how we know there is community spread, how we track the disease, how we follow up and understand now that there is community spread, and where the data come from to make decisions about social and physical distancing and hand washing and testing, and where we find the virus and how long it lasts on surfaces and all of those sorts of things. So I'll turn it over to David, who thinks about the public but is your clinician. So I'm not a medical person. I just think about bunches of people.
Thank you so much, Wendy. I really appreciate it and everything that you do. And I know we'll be fleshing that out much more with the Q&A, and some of the links I will take, the videos and the other links, and if, other things you want to put them in the chat room so people can access. Right. Dean.
All right. So I'm honored to be part of this group. as a participant, and to work, side by side even more now with Dr. Wendy Bernays. It's an honor. I really appreciate all the rabbis' kind words, and I'm just a healthcare provider doing my job, I feel, and that job has risen to new levels right now. And every day is different. Every day is evolving, and I at times know as much information as everyone else does, maybe a little bit before you know it, but also getting information from other ways. And for what I do on a daily basis, I'm sure everybody recognizes, but a lot of what I do comes from people like Wendy. The information that we get, from people who do the research and guide us, and that is evolving every day. And I get a lot of information from the CDC, from DPH, from the hospitals that we're affiliated with, Children's Hospital and Mass General Hospital specifically, that put out information every day on how they recommend the hospitals run, and also the practices that are associated with them run. And every day we are meeting in the morning to decide how we change things. And that is a good reflection of how things have evolved, even at a local level in the town, if not at Temple and Muna over the past couple of weeks, how we have come to various decision-making processes around the information that we have. It's really it's an interesting time, and I just feel that, again, I'm doing what I'm supposed to do, maybe in a different way. And my involvement is as Rabbi says and Wendy says, it's really more on a more not as much global level. It's in the office, but what we do is affected by from the community, and what we do affects the community. So I look to people like Wendy for guidance, as well as others around me, and I'm happy to answer questions as we go.
Great. Do either of you or both of you want to just give kind of an overview of where things are at right now in Massachusetts, a little bit of the latest data, and obviously recent decisions, including the governor's today, and maybe a little of insight into what's the thinking behind that?
I'll defer to Wendy to start off on this, if that's okay.
Yeah, I'm just looking for today's report. So every day we get a report from Lexington, and the sort of neighboring communities are part of it's called a regional, for this emergency anyway, is Region 4A, 4B preparedness group, and we get an update daily on the numbers of cases, the sort of the situation. And so for today, well, I haven't gotten it today. It will come later this evening. What we're looking at, and I'm sorry, I can't find it right now. What we're looking at is a rapidly rising increase in the numbers of cases. This is reflective of two things. It's reflective of the fact that we did not have, and we still don't have, sufficient testing to really understand the community spread of the disease, right? So we have had focus testing, and the focus testing has really been quite poor. The testing started out with the state lab, the State Department of Public Health lab, and excuse me if anybody here works for DPH. So the numbers that were reported, that capability was extremely limited. And the numbers of days to getting tests back was extremely long. And those are reported as presumptive positives, right? So then the tests had to go to the CDC for confirmation to get a confirmed positive. Since that time, which was about 3 weeks ago, additional tests have come online. And we heard yesterday, actually starting probably tomorrow, that there will be a much better capacity, certainly through the Broad Institute, which is MIT and Harvard, to be able to carry out a more rapid test. And depending upon the way the samples are collected, can either have less than 24-hour turnaround or a little bit longer than that. So what we expect to see once this testing comes online is that the numbers are going to appear to skyrocket. So are they skyrocketing because of great community spread of the illness, or are they skyrocketing because we're actually now getting a handle on the actual numbers. So people have been asking us in Lexington, the Board of Health, why are you not reporting the numbers of cases and the numbers of people who are in quarantine and the numbers of people who have recovered? We don't know what recovery actually looks like, right? The fact is that the CDC has originally said you needed 2 negative tests spread out by 24 hours in order to be considered no longer requiring quarantine. We've gone sort of a shorter distance and looked at clinical presentation now to make that decision. So as David says, and everybody says, this is evolving. So we expect in the next 3 to 4 days to see a very large increase. We don't report the numbers, for example, in our county, you can see the Middlesex County reported numbers. Towns around us have around 10, 12 something cases. But remember, there are criteria that are used to determine who gets tested. So healthcare workers, people on the front lines are getting tested sort of in the first category, high risk people, either because of exposure or because of their vulnerabilities. Those people are being tested first. So the people who, like many of us, are sitting out here, we're not going to be in that top tier. So those small numbers, if we were to report them, would probably result in either us saying, oh, things aren't so bad. We don't really need to be social distancing. We don't really need to be taking these really extreme precautions that we should be taking, right? And so it would give a false sense of security. And then when the numbers go up, then what? Oh, okay. So, and that's really important from a data perspective. So those of you out there who are data people, you get it. Small numbers will be misrepresented. There's a lot of qualifiers that go around those numbers, and yet we're sort of being pushed. Why are you not showing us the numbers? What are you hiding? So now you can say, nobody's hiding anything. We're just not testing enough. And once those numbers get larger, we will be able to better understand the distribution of the disease in our communities. We'll better understand whether it's close contact, whether, that is where we see most of the transmission. We'll get a better understanding of the age distributions of the moderate cases and the more severe cases. We'll really be able to understand much more about how infectious this virus is and how it is affecting people in Massachusetts and sort of in this region. Without that testing, it's a guess. We just have to look and see what happened in other places. And we expect that what's happening in New York is a function of population density and more testing. People in New York don't have different genes than we do, don't have different susceptibilities. It's about exposure.
So I would say ditto to everything that Wendy has said, and probably ditto to everything she will say. We have all these, a lot of us probably have these tickers, right, that show cases in various countries around the world and in the state. And I look at these, I look at these every day in the office. And agreeing with what Wendy said, it's really on my ticker, there's a green number, which is the number of cases, and a red number, which is unfortunately the mortality rate. And really the only number that really counts right now to me is the mortality rate, because that's what we're trying to prevent. And it's not the only number but that's a really important number, because the green number, the number of cases is going to increase immensely once we start testing appropriately. And again, with what Wendy said, the testing right now is really, it's less than dysfunctional now. It's getting a little better, but it's been pretty poor up to now in terms of who we can test. And there's certain criteria of who gets tested and, where you can get tested. And it's hopefully as new testing sites arise and better testing evolves, we'll have a much better idea of the numbers of this. And it's important to recognize too is yeah, not to rely too much on the numbers, because we have to, if you don't have accurate numbers, we have to assume they're only going to rise. And if we get complacent, they are definitely going to rise more.
So thank you both for those answers. I'm getting questions now by email. I see some in the chat box. So if you'd like to ask a question, you can do one of three things. There's a button that you can use to raise your hand. You can also physically raise your hand, and I'll write a little list in the chat box, or you can type your questions in the chat box. I'm going to start with a question I received by email, which is a little about this physical distancing. And I'm using that term instead of social distancing because I really believe we're trying to find social ways to connect, even amidst physical distancing. And the question is that there's been a number of articles recently that have mentioned perhaps we're taking the physical distancing too extreme or too long, and should we be, it's been mentioned that maybe there should be certain populations that don't need to. Can you speak a little bit to some of the disagreement about tenure and duration that's going out in the world today?
To the best of my knowledge, and this is based on the data that come in, from the scientific communities, there is no evidence at all to suggest that no one is immune to this virus, that no one is not able to get the virus, right? So does not appear to be any evidence that that there are populations who will not get sick. Okay, so that's one thing. We know, and David can speak to this, whether children are contracting the virus, whether they are contracting. We know that people can remain infectious or can be infectious for about 48 hours before symptoms appear. I posted a really wonderful video, I think, of what symptoms look like, and it's a really nice infographic video, so you can take a look at that. I think the second part of your question, are we going to extremes? And the answer based on what I have seen is no, we are not going to extremes. That the 6-foot distance is based on the distance with which a sneeze or a cough could spread droplets, right? And so we seek to keep that distance from another person. And, we think right now that the virus is spread through droplets, either directly or contact. You touch a surface that has viral particles in droplets, you touch your eyes, you touch your nose, you touch your mouth. People are trying to understand whether there are other ways that the virus is spread, perhaps through aerosols, through inhalation, right? Through inhaling. There is some evidence of that. We know that there are live viral particles in feces. So people are trying to understand whether there is an oral fecal route of exposure. We know this to be the case for things like norovirus, right? And other viruses, and also other bacteria, that if you don't wash your hands after you use the toilet properly and you touch your food or your mouth or hands and mouth, that you will get sick, right? So the question is, can we spread this virus that way as well? And there is some evidence coming out of some studies in Hong Kong that in fact this is so. So one of the recommendations that is made, if there is a case in your home, is that if possible, that person who is now isolated, so isolation means that you have the disease and we're isolating you from other potentially exposed people. The people who may have been exposed to you are quarantined. So quarantine means you may have been exposed, but you don't actually have the disease, to the best of our knowledge. So if you are quarantined in a home with someone who has COVID-19, the recommendation is that you use a separate bathroom, right? That you all of your food stuff, all of your toileting happen away from the rest of the family to try and reduce any potential exposure. Again, we don't have hard science on whether there is an oral fecal exposure pathway. We don't know yet.
So just jumping, I think one of the parts of that question is we are now treating everyone in the office who walks into the office as possibly contagious. And this comes down from what the hospitals are doing, such as Mass General Hospital, a partner system, Brigham and Women's Children's Hospital. So again, this is different than it was a week ago. So everybody that comes in the office, especially kids, we are told to be considered as contagious. So we are, our usual hygiene, of course, we're hand washing and whatnot. But the recommendation is to wear gloves when examining every patient. Wear at a minimum a surgical mask with every patient. If there's a higher concern, a higher level mask, N95 if you have it. Some are lucky to have them, some are not. So to answer the question, would I agree with the recommendation of just to isolate or quarantine high risk people? I'd say no, because the people who are walking around, the more people that get this, there's the higher chance to expose people at risk. And there's this, Wendy sent out that very nice video, I think, yesterday. And we know the high risk groups. We know some of the high risk groups, and I'll go back to the evolving term. This is changing every day. And just because I'm not over, is it 60? I'm not over 60.
No, it's 67 now, I think.
Yeah.
So
I've got a little more leeway right now, but just because I'm not 67, that could change in 2 weeks that I could be high risk. For all I know, I have underlying high blood pressure, or we're hearing stories now of middle, whether it's toddlers or infants, of course, which are now I think is at a high risk under a year possibly. I don't know if that's confirmed yet, but I get stories every day or news every day of supposedly healthy 20 and 30-year-olds who are succumbing to this illness. We don't know the underlying health history yet, so I can't make an assumption, assumption that they're totally healthy. I mean, on a side note, vaping and smoking and marijuana use are now being thought to be possible high risk factors. And as I say these things, I mean, the internet is full of anecdotes and recommendations that have not been confirmed about certain things. So I don't want to make any decisions about those things. But I think that we have to consider that anybody really could be at risk. We just don't know who that. We know who is definitely at risk, but there are people who could be that we just don't know yet.
And I think we can go to the questions in a sec.
Yeah, I'm going to go to the questions in the chat if that's okay. The first one from Irene Waxler is speaking about things that we can do to protect ourselves. For example, can we buy fresh vegetables? How should we store them? Should we leave boxes from Amazon on our doorstep for 24 hours in cardboard before bringing them in? Something for 3 days? Give us some insights as to how to live our lives.
The basis for this 3 days is a study that examined the ability of the virus to remain alive. Viruses aren't alive, but to remain potentially infectious for up to 3 days on some surfaces. And there are some studies that show that it's even up to 9 days on other surfaces. So there is no question that this virus is able to survive on surfaces and to be able to remain infectious, certainly for probably up to a couple of days, if not a little bit longer. And I think we have to think about this balance between making ourselves, as my mother would say, so famished that we can't even function. And I don't know if my mother's still on, and other from doing what we can do to prevent infection. Okay, so in terms of if it's convenient for you to leave the boxes out for 3 days, well then go ahead and do that. Do you have to wipe down every grape? I don't think that is necessary. Do we have to eat healthy foods? We absolutely have to eat healthy foods. If we build our immune systems, if we maintain healthy immune systems, we have a much better chance of remaining healthy even when infected. So again, I think I would never say, don't do this, don't buy vegetables. I mean, we need to be able to eat, we need to be able to eat fresh fruits and vegetables. I would suggest washing them. If they come packaged, you know, I would still wash them. Again, I think it's about, your objective is for you not to get sick, but really for you not to spread the illness, right? So if you are in the vulnerable category, then some of these actions might make a lot more sense. For others, it might make you feel like you're doing something. But I think the distancing, the wiping down of surfaces with disinfectant, those go a very long way. And, you know, the order to stay at home, stay at home. And, you know, we've been struggling with, how do we write this in such a way that we don't sound like we're taking away every civil liberty? On the other hand, it is really serious, and we do want people to stay at home and to wash and to, you know, take measures that could decrease their exposures. I don't know if that answered that question.
Yeah, that was great. The next question is from Mark Drury, who writes, two-parter, confused by the statement, quote, for some individuals, symptoms might be mild and could be easy to dismiss them as a common cold. However, an infected person can spread the virus even when they are asymptomatic. My understanding from Dr. Fauci is that symptoms present themselves more like the flu, fever, aches, heavy chest, and not like an upper respiratory cold. And second question, following up on what you said earlier, is 48 hours now considered the period of time that an asymptomatic person can be ineffective?
So I'll let actually David speak to the latter one, but
I
you're
wanted the first one.
Oh, you want the first one? All right.
No, I'm sure you go.
No. Okay. I'm going to see actually. So I'm going to show you. I'm going to show you a graph, because, you know, a day without, you know, 6 hours of teaching is like a day without sunshine. So let me just share my screen here. Let's see. I'm showing you a picture of, this is actually looking at two other infectious diseases. Really bad one, Ebola, really bad one, chickenpox, right? But we think of chickenpox as not being really so bad. And we now have a vaccine, of course, for chickenpox. What I want you to look at here is there are really sort of four terms. One is an incubation period, right? Which is the time that the infectious disease is actually in our bodies. It's growing. It's not yet, we're not yet manifesting any clinical signs, and we're not yet infectious. We'll ignore the green part. And then we go to the purple, which is where we're clinically ill. And we can have mild symptoms. We can have severe symptoms. And then we look at the pink one, which is when we're infectious. So for Ebola, people are not infectious until there is clinical illness. Take a look at chickenpox. You're infectious before you have symptoms. So from a public health perspective, I'm more worried about chickenpox than I am about Ebola. If we look at COVID-19, we look something more like chickenpox, where we're infectious before we're clinically ill, before we present with symptoms. And in fact, we continue to be infectious through a good portion of that clinically ill state, and probably a little bit later. David could speak to this. But my point is that you can be infectious before you're clinically ill. And that's the really hard part of this disease, right? If we knew that when we presented with symptoms, that's when we were infectious, this would be a lot easier. So Mark, I can't remember your question. Let me see. Yes, for some individuals, symptoms might be mild and it could be easy to dismiss them as a common cold. Okay, so there are certainly people who get, they have a sore throat, they have a fever, they may have some upper respiratory, not usually head, but upper, sort of throat and a little bit lower. And to dismiss that as a common cold. However, an infected person can spread the virus even when they are asymptomatic. And that's absolutely true, right? So you saw that. And Dr. Fauci said that, and he is our, we look to Dr. Fauci like others look to Moses, right? I mean, let's hope Dr. Fauci can survive Mr. Trump. Dr. Fauci said that symptoms present themselves more like the flu and not like an upper respiratory cold. So, we're hearing a lot of different things. I posted a video, which is really, really good. You'll see what the major symptoms are. And I think that'll be really helpful. The second question, that's for David. Sorry, David.
No, I think you might have answered that.
I actually did answer. Did I answer it?
Yeah. But I think that a couple of things I would say is right now, and just as a personal experience, when this all started out, we were screening people who had fever and cough and chills, fever and or those things, and had a known exposure or traveled to a certain country. That's changed now. I mean, basically, if someone calls the office now and says, not that we have to follow these guidelines, we have to kind of use our own intuition, like a gestalt. But if someone calls the office and says, I have a sore throat, technically we have to consider that they could have COVID-19. That's a symptom. That's it. No fever, no cough, no body aches. I have a sore throat. That could be COVID-19. So that's those are the mild. That's a mild case, and then again, there's asymptomatic cases. And I think that with what Wendy said, that the contagious period can be at least 48 hours, I think, before you show symptoms.
Right. Right.
And then for an extended period of time afterward, I think the criteria have changed recently in terms of when you can, as Wendy said, the CDC has come up with different guidelines recently, I think, and if you have a positive test, you have to be at least symptom free. Wendy, can you answer this? For how long? Like before you have to be, your symptoms need to have resolved. I know that, and you have to have you have to have two negative tests.
Yeah, not too much anymore. There's a little bit of fuzziness, and there may be another clinician on, or Marcy may know the answer for today. I just don't know.
Yeah, I think that some of the guidelines I have is 3 days. You have to have 3 days of fever free and at least 7 days from the onset of symptoms.
Okay, all right.
That's what I understand now.
Right.
So.
And part of that is this is going to evolve as either the tests get better, or frankly, there's some observation that, there just has to be a practical decision that gets made.
So I'm going to jump to Alice's questions. She has a couple different ones. We'll try to put them into one. What about distance when you have no symptoms?
So the distance still holds. It still holds because you can still be infectious when you have no symptoms.
And then her second question is a little more complicated. She's helping her mother, who's 100 years old, but she's in the risk zone herself, reluctant to visit her mother, but she has no choice other than wearing surgical masks and gloves and hand washing. What are the things that she can do? Does limiting the time together have any value in reducing exposure? Some thoughts about how we care for one another at such a time.
Well, this is like a clinical thing. This is like a one person on one person. But so I'm going to assume, Alice, that your mom is living in her personal home and not in a care facility.
Yes.
Because unfortunately, I know my mom is safe. I can't go see her. So, and others I know are in the same boat. I think if it were my mom and she were living at home, I think I would go live with her and I would just stay there. And I would not keep on going back in and back out and back in and back out. Because every time one goes out, there's a potential for bringing the virus back in. David?
And you're talking to someone whose mother, who's 80 years old, is still trying to come to work at my office every day. And truth be told, and I'm working on arranging that not to happen. And this is her connection with life in a way. But I also want to have to keep her connected to life. So my quick answer, and this is where it gets, there's nuances here, is I think that Alice could visit her mom. I think that she could come and go. I would recommend the highest level of hand washing, inside and outside the house in general, just to protect yourself, Alice. I would make sure that you're wearing a mask when you walk in that house. I would make sure you put on gloves when you walk in that house. I would change your clothes, maybe into new clothes from a bag when you get into that house. And when you leave, you can leave those clothes there and change out of them or bring them back home and wash them. But I would have it, like when I come home now from work, I'm considered I'm covered in something, and I change before I even walk inside. Even to be 100%, even safer, you might bring a mask for your mom to put on when you're there. Again, 2 weeks ago, people would say surgical masks have no value, but they have some value. And I think that I would lean to, the balance of what Wendy's talking about, of eating vegetables to stay healthy, seeing your mom, there's a lot of benefit there. And I think that if you practice this is me talking, like if you practice really good hygiene, I think you could see her.
This is intense and hard stuff for all of us to take in. Can you speak to a couple of different questions that have come in here? We got a lot. I don't know if we'll get to all of them, but one is, do we have to wash our hands frequently once we are in our homes? Assuming we come in, we wash our hands. Now we're in our homes, we're with ourselves or with a couple of people. What is then the protocols inside the home if we've created kind of a little, space inside the home for ourselves?
Well, I think it's different if you're the only one in the home, right? If you live by yourself and you're not going out, then of course you would always wash your hands after you use the bathroom. You would always wash your hands, before you eat, because that's what we do. If you are the only one touching the surfaces, well, then just wash judiciously when you can. I assume that somebody is bringing you stuff, right? Or you're going out to go to the supermarket or where you're going. So you're going to be washing, even when you're coming back.
Do you have that same recommendation for all of us going to the grocery store, that we should assume that is such an experience that we should take off what we're wearing? I mean, are there some tips that can reduce our exposure when we all need to shop and do what we can? Are there shopping tips?
Well, I'll remember my father, who could not believe that when our babies were born, you don't take your infants to the supermarket. There are a lot of germs there, right? So if we think about that, he was right. And, I think we're using, if we look at the orders that have come down from the governor, from other governors, you're allowed to go out in order to go food shopping, in order to do a very small number of things. And you're really going to do this wherever you're going to get your food, and you're going to come back, right? And so, again, washing, if it makes you feel comfortable to switch your clothes off, it depends, again, who you're going home to. Are you going home to yourself? Well, I don't know.
Okay. Dave?
Yeah, I think in the house, I'm sitting here touching my face nonstop, right? As some of us are. And I think we should be washing our hands well. I washed them when I came home. I actually I brought my computer from work home, actually, so I could use it as a better camera and microphone on it. But I actually wiped it down. And I think that's good practice and good hygiene in your house. I don't think you have to wash your hands every time you touch something new in your house specifically, but I think you should, when you're hands are going to your mouth, the eating, the toilet is I mean, that to me, the stuff that's coming out from this awareness of this virus in terms of how we should live our daily lives, not how I should run my office in terms of just the highest level of hygiene. I don't have to go crazy, but this is some good smart practice we can all put into practice. So I don't think you have to change your clothes specifically when you go to the grocery store, because you're not, unless you're hugging someone or really coming into contact. But I think, again, washing your hands when you come back inside, I don't think it's a bad idea in general. Take off your shoes. That was my father's, always the shoes, the dirtiest part of your, anything you wore. If I touch my shoes, and especially in synagogue, I'd have to wash my hands. But I think that we should just practice, good hygiene in the house. But Wendy's point is well taken. Like, if you're, like, I have two older girls who are still seeing a couple friends here and there that we're comfortable with. I don't know where those friends have been sometimes. So I think we just to be more aware, and I think washing is a great thing.
All right, we're going to go to a slightly faster round of questions. A lot of questions. I want to be
Speed round.
Speed round. This one from Alan Silver. How long can the virus live on a surface that is either a refrigerator or freezer? And I'll go to the inside. Do cold temperatures affect the virus? So if something I put in the fridge, does that necessarily kill the virus, or the freezer?
Probably not. Viruses are not alive, right? And so we are looking at the viruses as having the potential to infect, but we don't have hard data on what temperature will kill them. So I would suggest here that we don't know this at this point.
Okay. What about microwaving foods? Does that, do we have any information about that?
We actually don't have much data at all about the behavior of the virus on food.
And boiling, I assume.
And we don't know actually if we contract the virus, right, through food. We don't actually know that, and there is no evidence at this point that consuming food that contains virus is going to result in infection. We just don't know.
Okay. And on the surfaces of, like, your refrigerator door and other frequently used things like that?
I'm sorry.
On the surface, like on the outside, so it's room temperature.
So again, it's about touching it, putting your hands on your eyes, putting your hands in your nose, right? So that the virus, again, it's spread, and you're looking for a way of moving that virus from the surface into your, sort of your upper respiratory tract so that it can infect the cells.
In terms of the duration, I think Wendy's taught me this, or with the papers that we've shared, is that it initially was thought to last 48 hours on surfaces, and now the range is 48 days, 40 hours. Yeah, now it's 3 days to 9 days, depending on the surface. So I think, these are studies that are coming out, so everything really depends on the surface that it's on. And so I can't what they showed about.
The other interesting thing we don't know, it's called an infectious dose. We actually don't know how many viral particles one needs to actually be infected. So when you sneeze and you're in the you've all seen that Doc Edgerton picture of the sneeze, right? You're getting a whole lot of viral particles in those droplets. So, if you've got viral particles on the door handle, for example, right, and you touch it and you put, your hand to your eye or your nose, we actually don't know how much is needed to actually infect a human being. That's the science that we need.
Okay. From Glenda, do people develop antibodies to this virus, and can people who have had the disease be reinfected?
We don't know about reinfection. People are studying that in China. There is a couple of cases that suggest that a couple of people have been reinfected, but we don't know whether they were actually reinfected, or there's a different strain, or whether they were never really recovered. So that's not yet known, Glenda. We'll learn that with time. Yes, people do develop antibodies, and that is the hope, that over time we will develop antibodies. And one of a number of the tests that are in development for determining whether you have been infected will be an antibody. We will be looking for antibodies. Yeah.
Dave, if you want to jump in, let me know. I'm just trying to
Yep.
speed through some of these
Good.
more. From Marilyn Tracy, has vaping contributed to the spread of the disease since water is involved, same as Legionella?
Yeah, I don't know if we know any of that in terms of the spread. I think there's as I mentioned, the concern is more is underlying lung damage making symptoms worse, disease worse for some people. I don't know if we know that. I do know in the office, in the hospitals, we are not allowed to use nebulizer machines anymore. Those are machines that we often use for people who have asthma or wheezing to open up their lungs. It nebulizes the medicine to a mist to breathe in. And the worry is that if they have COVID-19, that will actually spread it more through the office. So definitely the aerosolization is a risk.
Right. And I think that gets to the Legionella because that's an aerosol, right? That was spread through mechanical systems such as the heat ventilation systems, right? Yeah. And so we actually don't know. There is some suggestion that COVID-19, that the virus may be spread through aerosols in a similar way. But again, we don't have the data yet.
Okay, from Hal is asking kind of a tricky question. What is the responsibility of the infected person and their family to notify everyone in their circle of their diagnosis from a public health perspective and then from a Judaic perspective? I'll let the public health go first.
All right, we can do the public health thing and then you can do the other part. So we have a process, right? And this is called disease tracking. So the objective is to understand who has the disease. So you are infected, you have a positive test. And that test, then the results of that test, like for any reportable disease, go from the laboratory to the State Department of Public Health and to clinicians. And then what happens is, and to the local health department. We get the report. The public health nurse then calls the infected person with the disease, and follows up with them, right? And tries to understand exactly where they have been for 14 days. Now it's actually shortened, but it had started out at 14 days prior to their test, their positive test. You can imagine many of us can't remember what we did yesterday, let alone 14 days ago. So that's been shortened to really try and understand, you know, sort of the bigger picture of where people have been. So those are called the contacts. The contacts are then contacted, and the public health nurse will discuss with every single one of those contacts and ask about 50 questions to determine whether exposure was sufficiently significant to warrant quarantining those contacts. So in terms of the public health response, with any positive case, that is a requirement by law for that tracking to occur. That is the way that the epidemiologists, so we've heard that term, epidemiologists, and an epidemiologist is a person who studies the causes and patterns of human disease. So an epidemiologist then would look at the data and try and understand the transmission, how many people got infected, how, you know, sort of how many, how the transmission occurs to how many people, and can ultimately determine sort of the real rates of infection and the real rates of morbidity and mortality. Absent a positive test, if you have somebody who says, well, I think I have COVID-19, well, there is no sort of responsibility on the part of there may be, you may feel that, you know, I need to let people know, but without a positive test, how will you know then when you're going to release yourself anyway? So I think there is some, and this may fall into the rabbi's realm, sort of at what point do we have a responsibility? Your employer cannot demand that you call and tell them that you have COVID-19 if in fact you don't have the test. They might have some recommendations, but again, we're getting into the legal aspects of of the violations, whether it's HIPAA or not. And so these are very sticky matters that I think some of our legal experts are going to have to help us grapple with.
Dave, did you want to jump in on this?
No, I think that was pretty complete.
Okay, well, I'll offer this teaching, which is that there's two very key pieces in Jewish law. One would be pikuach nefesh. And if anything that you can do that share information could possibly save others' lives, and obviously, Wendy just spoke to tracking back to people, and that could then prevent other people from getting sick as more people quarantine themselves. That would be an onus on you. And then there's another competing value, which is, halvanat panim, and embarrassing when someone, and so you also want to be sensitive to someone's privacy. Here, pikuach nefesh would take precedence, and therefore, if there's any data or information, because you came into contact with any person that would either endanger their life or help them, then you would be required to share that so that they both could take care of themselves or people that they come into contact with, family or friends. We'll keep going with a couple more questions as we're winding down. I'll kind of will through two little ones. Is there any danger in walking your neighborhood or walking your dog? About treatment from Gila, is it clear whether NSAIDs like ibuprofen are less safe to take than acetaminophen, as we all take medicine? And then I'll do a more serious, more intense question after these two.
Okay, you should walk your dog around the block.
Great.
Agreed.
Your dog it does not carry, nor does it transmit COVID-19, and you need to get out and get some fresh air, but by yourself. Go.
Great. Okay, is it safe to walk with a friend if you remain 6 feet apart?
Yes.
Okay. Bike riding, those kinds of activities?
Yep.
Just
Now
not in a
safe-
tight.
Not just what?
Just not in a tight pack.
Mark.
Well,
Yeah.
Now that there's so few people on the road, it might be the best time for bike riding.
Actually, we have suspended our group rides, and we're not riding in packs. We are actually keeping 6 feet apart.
Your Arlington
great.
Board of Health told you you needed to.
No, we did it before the Arlington Board of Health said so.
A couple more meta questions, which is obviously the governor announced that he lengthened the closure.
Actually, if I can just the answer the NSAID question
Yeah,
and
sorry.
the benefit
Yeah.
question, which I think Wendy may or may not agree with me, but there was some information that came out a few weeks ago from limited information that NSAIDs like ibuprofen could worsen the disease if you got it. That has not been confirmed. I think the World Health Organization did issue an alert initially saying you should use Tylenol first, and avoid NSAIDs. They retracted that, I think, saying that there is no data to support that you cannot use ibuprofen or other non-steroidal anti-inflammatories.
I'm not going to dispute. Right on.
Great. And washing sheets more frequently, is that just like a good general hygiene idea? But
That's fine. Depends who's doing the wash.
there you go. Okay, well, we'll be careful. Let's ask a kind of trickier question about the governor's change to keeping schools closed into the beginning of May. What was some of the thinking behind that decision? And that's from Maya and from Jessica. Is there a plan, kind of an end game? What's the plan to get out of all this? Is it just to wait it out for the country? I'll ask my own piece. Will there be like releases? I read an article that said we'll be like open for a month or two and then close for a month or two. Are there any thoughts about that, or is it just wide open?
Let's see. I'll look in my crystal ball.
Yeah, please.
And okay, I can speak to the school closure. So I
Okay.
did post, I think in one of the links, I posted sort of our criteria for decision making for closing the Lexington schools. I have to give an amazing, shout out to the Lexington school superintendent, who really took the reins on working with the region to get a regional school closure. We worked with her, and we have an ad hoc group of, we'll call them advisors, scientific and medical advisors. And we came up with that, those criteria. And if we look at those criteria even today, we would say there is no way that April 7th, we would be able to meet those criteria. So I think the governor is recognizing, A, the numbers of cases will definitely be increasing. I think the reality is that there isn't, I think, an ID epidemiologist who would say that we're free and clear by April 7th.
Do you want to add some more on that, or on the
Yeah.
we start releasing ourselves from this? Is it a gradual process? Is it faster? How do we think about that? Are there any thoughts on that?
Yeah, and going back to Wendy's crystal ball, I was, we did a lot of stuff I've been reading, and it was a gentleman who said he has a great retrospectoscope, but not a great, prospectoscope. So there was a young man in the office today who said to me that his friend said that it would be back at school April 7th. And I said, I said, not that I have inside information, but you should make a bet with this young man and say at least April 15th, if not, through May, and I'm happy to spot you the money if you lose it. And he went to the waiting room, and about 10 minutes later, we saw the message from the governor that May 4th. So I think that I think it's going to be an extended period of time. I'm happy to put my thoughts on that. I think the concern would be if we went back too soon and got complacent, it would rise again. So I have no idea. I think we're in for an extended period of time. That's just my gut, and that's just as I'm learning things. So yeah.
Thank you. We said we would be very respectful of everyone's time. I want to bring this to a close. First of all, thank so much Wendy and Dave, who not only are giving their time to all of us and to anyone else who enjoys these links and watches the recording, but to the whole community. As I open with, it is really a Kiddush Hashem. It is a sanctification of God's name in every way. Or as Isaiah says, you are God's witnesses, and we hopefully through the insights and great science and great skills of communication that we now have can prevent something that, maybe a century ago was much worse. Maybe humanity can do something to make it much better. And our tradition is certainly mandating that. I've seen things from Orthodox circles that I never would have imagined seeing, including from a Sephardic rabbi who said you should stay home and have a virtual Zoom Seder, and allowed that to go on before the holiday and remain how you will have your Seder on Pesach. So we're seeing rulings from corners of the Jewish world that I could not have imagined. We will be sharing more of that kind of information, and how we as a community can continue to share. And I think just seeing each other's faces and, getting this information from people that we see in shul makes it, I think, much more powerful. And I don't know if I can put you guys on the spot, but I hope you'd be willing to do this again next week or at some point as we need to connect and share information, and really also share the difficulty, right, as we try to make decisions about how we're going to live our lives, how we're going to get groceries, how we are going to take care of our loved ones. That is incredibly complex, and the kind of emotional qualities. And I appreciated hearing a lot of the similarities in your approaches, and also some of the nuanced differences as each one of us struggle with these choices, moral, ethical elements, and bringing our own Judaism into it. I think that's what our tradition has always been about, taking the best ideas from the world, bringing them into our sources and tradition, and trying to bring them all together. And that's certainly what we are all doing at this time as we build a social community with our physical distancing. So thank the two of you. I thank everyone who's on the Zoom this evening. Tomorrow we'll have a regular minyan, virtually regular minyan at 7 a.m. There'll be meditation at 4 p.m. and there will be an evening minyan. And then Rabbi Kling-Perkins will be teaching about the Seder and leading it. There may be people who've never led a Seder or dealing with all kinds of parts of Pesach. So she'll be leading that this Thursday night, tomorrow night, and the following Thursday. And then on Friday afternoon, she'll be leading a Nigun Saloon. So if you'd like to sing, there'll be an opportunity for that. And we'll be back for Shabbat services. We may start a little earlier this Friday night at 6 p.m. We'll be sending out that information. And that might be more in this meeting format where it's a little bit more seeing all of our faces. Shabbat morning, we simply have too many people to do it through this format. We'll be again in a webinar format, again at 9:30, and then hopefully another Havdalah sing-along on Saturday night.
Rabbi,
My services are
tomorrow is
45.
6:45.
Excuse me?
6:45 tomorrow for Rosh Chodesh.
Oh, great. Thank you very much. Thank you. 6:45 in the morning, bright and early. But you don't have to go that far. So, you know, there's some pluses. Right, and 7:30 in the evening. And then Friday night, we're going to move up to 6 p.m. with Mincha. 6:15 will be Kabbalat Shabbat, and we'll be sending out links and information on that. And the people who are participating in the Shabbat morning service, again, will be on a webinar format and to kind of make our way through all the logistics of that. If there are other things that folks can use, please don't hesitate to be in touch. I was just, you know, on the phone with many different people, many different needs, and we're trying to meet all of them. So please don't hesitate to reach out. We have an amazing community of volunteers and staff who are really working, you know, 18 hours a day, every day, primarily through Zoom and other technology to make sure that we are connected and that we continue to sustain one another. So thank you for that, a great gift, and wish everyone an early Shabbat Shalom.
Shabbat Shalom.
Tov.